we had a very wonderful list of 9 questions sent in by people. All right, my question's over here, so I'm going to look back and forth between this monitor and that monitor. What are the drugs that are used for ICI dosing and the suggested dose? We covered that pretty well in this seminar, but just to be clear, start with number 5 and then work your way up or down depending on the response in the office. The suggested dose is going to be 20 units every time, right? So that's why I'm going to give the guy 20 units, and at home I want him to start at 20 units and then adjust as he sees fit from there. For example, you'll have a guy who, they like to go to dinner after they have sex, and so he has a 3-hour erection, and I say perhaps scale it back from 10 or from 20 units and go down to 5 and work your way up from there. At 5 units, he has a 45-minute erection. That works perfectly fine. He and his wife can go out to dinner. But at 20 units, he's, awkwardly not going to dinner for about 3 hours. Question number 2, the vials are a big patient expense. I hear you, but one point about this, MenMD has really, really good pricing. Part of the reason, I love this company is because the pricing is comparably excellent to other compound pharmacies and is very good, and there is an extraordinary degree of customer service that comes along with that pricing. So, moving on from there, the rest of the question, what instructions do you give regarding freezing and refrigerating vials? It's a very good question. I think the most important thing with refrigeration is a lot of the local compound pharmacies around me mandate that the patients freeze the medication, which is rather inconvenient to have sex later on, right? So, for example, if the guy freezes the medication, comes from some compound pharmacy in upstate New Hampshire, it's like when you take a pork loin out of the fridge, you got to eat it the next day. You know what I mean? Like it's got to go in the sink to defrost for a little bit, or in the fridge to defrost for a little bit, and eventually you take it out and go from there. It's a lot of extra step I don't particularly love. But you have guys that don't go through a full bottle in a 2 or 3 month period, and they just don't use it that often. So refrigeration, I think, is pretty good. I'm going to give you a little bit of off the record. MenMD doesn't hear this kind of stuff, and that is this. When I talk to guys at their follow-up visit, what I say is, look, the beyond use date on your vial is going to say 28 days, discard within 28 days. There is good reason for that. The pharmacists do not know you personally. They don't know that you are a guy who will clearly wipe off the top with an alcohol swab of his ball every time he uses it, and then will refrigerate it properly and not leave it on the countertop for 2 or 3 months in a row. So if you treat the drug properly, you refrigerate it and you wipe it off an alcohol swab before you use it, you can probably get about 2 or 3 months out of that dose. If you find you're not having success and the dose has been in the fridge for a while, perhaps it would be prudent to order a new vial. But again, you can probably get 60 to 90 days out of it. That is not from MenMD. That is from me personally. That is my opinion only. Do as you see fit and what's appropriate for the patient. What concentration and dosing protocol do you recommend for post-robotic prostatectomy patients? This is a loaded question. If the question is for penile rehab, I will emphasize that the literature is there's no, let me phrase this delicately here and diplomatically. There is no convincing literature that penile rehabilitation works for post-prostatectomy patients, period. There is literature. It is not convincing, it is not clear, it is not clear-cut, etc. So if you're implementing an injection protocol to try and restore native erectile function in a rehab fashion, I am dubious that will be successful for the patient. Part 2 of this question is, what would you give a guy who just comes in and he wants to use injections and go from there? Also a bit of a loaded question. Here's my opinion. Again, my personal opinion. I often find that injections do not work particularly well for patients who've had prostate cancer treatment, whether it's radiation or surgery. Those guys, along with Peyronie's patients, tend to develop venous leakage erectile dysfunction, a function of the neuropathy, for example, or the issues with the nerves after surgery, or the nerve sparing or non-nerve sparing, whatever else. But they tend to get venous leak, whether it's radiation or surgery. And venous leak ED does not respond great to intracavernosal injection because venous leak does not keep the blood in the penis, right? So you can pump as much blood in as you want, but you're never going to get to that pristine, awesome 10-to-1 ratio of blood in to blood out that you need to get and maintain a really good erection. Usually 30 centimeters per second peak systolic and less than 3 end diastolic. You're not going to get to that ratio when a guy's got venous leak. So I'll walk them through the protocol and I'll say, look, if you really want to do injections, I'm happy to do this. I'll start with number 5 and work our way up from there and see how they do. I don't often find they have great success. I sometimes find they have a paradoxical response I don't like, or they have neuropathic pain because of the prostadil. And the caveat to all this is I often find that those prostate cancer treatment patients are the most reticent to pursue an implant, which I think that they need, and the most interested in pursuing injections, which is difficult. The logic I've come up with this over the years that makes sense is that my impression is that these guys, the last surgery they had was devastating to their penile health. And the prospect of another surgery to restore that health does not appeal to them very much. So they are eager to try injections to see if that works. And sometimes of the population that is the least likely to find an efficacious response in that circumstance. That said, you walk through the process same as everybody else. It doesn't work, it doesn't work. The good thing about the penile ultrasound is you can look at it and say, and here's why it's not working. Look at this monitor. It says, your peak systolic is fine, your end diastolic is half that. That is not a ratio that's 10 to 1. It's a 2 to 1 ratio. I can't get you to 10 to 1 ratio with this. We might want to move on. But again, when do you choose Bimix versus Trimix in concentration? I tend to stick with Trimix most of the time. I tend to use Bimix in circumstances where I want to really scale it back because there's been concern for priapism. I'm not a huge Bimix user. There are many people in New England who use a ton of Bimix. They are more comfortable with that. They find that the pain is less. So I would put a guy on Bimix when he's had evidence of alprostadil related penile pain, for sure, no question. I will put him on if he's had evidence of priapism, sure, no question. But I don't really start with that. I tend to start with big guns that I'm pretty confident are going to work, and that tends to be Trimix. And from there I move up. For the most part, for the vast majority of patients, I move down sparingly. The best options for men with priapism using low test dosing with Trimix number 9. This is an interesting question. I'm not really sure what the question is actually asking, but I suspect what the question is asking is if I'm injecting 9 in the office, what dose should I give them? I'm going to tell you a story. Early on in my career, there was a period in time when all that was available was mix number 9 for one of the days that I was doing penile ultrasounds in the office. So I only had 9 to work with. That partly was my fault. It was an ordering issue, and that has since been completely resolved, never happened again. But I only had number 9, and so I went with the day saying, all right, I'm not great at math, so I don't really know what concentration to reduce this to. Let me just try it at like 5 units with every guy, which is, it seems like a quarter strength, which is, 9 and 5 are 4 times different from each other. So I give them a quarter of the usual dose. I give them 5 units instead of 20 units. Maybe this will go well. I had 2 priapisms that day of the 8 guys I injected, and they were really prolonged priapisms. So my response to that question is, I would stick with number 5 as the starting dose for everybody, unless there's evidence that they've previously failed other medications and go from there. MenMD happily packages and ships out a lot of number 5 test doses. It is the standard across the board. Stick with that. I wouldn't try to adjust to a lower dose, but non-standard strength like number 9. It's really not a. I didn't enjoy that day. I didn't enjoy fixing 2 priapisms that day. It was a lot of stress. Put me like this closer to a heart attack. So I'm not thrilled with that idea. When needing to increase the concentration of the ICI, is your preference to increase the concentration or change from Trimix to Quadmix? Again, I'm really going to jump to Quadmix only in the circumstance where I've run out of strength in my Trimix mixes. I have a lot of confidence in mixes 5 through 16, 5, 8, 9, 13, and 16. I'm going to just go up that ladder until I run out of room. And when I run out of room, I'm going to go to Quadmix extra strength, which is now twice as strong as mix number 16 with some atropine on the end. other rationales for using the lower strength trimixes besides the risk of priapism is, again, when you decrease the dose of alprostol, you decrease the penile pain quotient. So a lot of those trimixes, 14, 7, et cetera, were invented at BMC back in the day at Boston University to give options for guys who are complaining of penile pain with this stuff. So you have a lot of flexibility. The reason I have such confidence in the system is because there's 16 different options here. I mean, you have a ton of options to work with here. So, you can really work your way down or up based on priapism and or pain as the response, and of course rigidity as the parameters you're trying to gauge here. Can patients become immune, in quotes, to Trimix and therefore need to increase their dose over time? Absolutely. This is a known quantity with Trimix. When I counsel a guy about intracavernosal injection, what I'm usually telling him is that you will get probably on average a 4 to 5 year response with this medication. And in that time frame, we will have to increase the strength as time goes by. And at some point, we may run out of strength. But this is like all medications, the efficacy of this wears out over time. It's still an awesome magic trick. I mean, when it works the first time, it works great. You're really happy with it. But over time, it loses efficacy. And that is the fibrosis that develops in part, but it's also the progression of the ED. This is not solving the ED problem for the patient. It's simply giving them a lot of blood push in their penis, which doesn't solve the problem. It just fixes it temporarily. And as time goes by, the ED worsens. The deposition of fibrin and collagen and sort of things that cause fibrosis in the penis progresses, and so things don't work as well. It's no big deal. I mean, for example, if you have a guy who's coming in at 74 years old and wants to start Trimix, and you tell me you get 5 years out of that, that's the last 5 years of his life on average, right? So that's a pretty good odds that he's going to have a lot of sex with your handiwork in that time frame. If he's 42, it's a little bit different. But anyway, how do you quickly establish a Doppler clinic at a satellite site? Having trouble getting ICI meds to the clinic in time for the patient. So, very important. When you sign up with MedMD, you will have a dedicated customer service representative, physician representative who's going to work with you very closely. Mine is Maria Canty. She's great. She's worked with me for the last 5 years, and prior to that, I've had a couple of other great ones as well, and they're very helpful. So if you're having problems with getting this logistically delivered to your clinic in time, talk to your rep, and they will help with this process. And when you go to SMS or when you go to AUA, stop by the booth and see Chelsea. She is the boss of this process, and is phenomenal in ironing out issues, closing loops on stuff, making sure things get done in a timely and effective fashion. This team really wants you to succeed and really wants to help. How do you quickly establish a Doppler clinic at a satellite site? Or how do you establish a Doppler clinic in general is not within the parameters of this seminar, but at the same time, email me, martin.s.gross@gmail.com, and I will help with this process. You come to visit me, you come to visit somebody local to you who does. I know people who do a lot of ultrasounds near you. You get this process up and running in a timely fashion. I find it's very helpful to have an ultrasonographer help with this process so that we're tag teaming this patient. And he's, scanning and I'm taking the numbers. I have a fantastic ultrasonographer, Evan Smith, who's been with me for many, many years. And he's really great. And we have a system that works fantastically. The one drawback of that system is that we've been doing this for so long, we make the same jokes every time. The good thing is the patients are new to us, so we get a laugh every time, which is fantastic. Last but not least, any issues with ICI and anticoagulation or any other medication contraindications. Anticoagulation is tough. You really have to hold pressure on that site for a little bit. The bruising can be significant, particularly if the patients accidentally inject through a vein and they poke a hole in the vein, then that bruising is going to be pretty prominent. Holding pressure is the most important thing. But I got guys on, Plavix, and Coumadin, the whole laundry list of all these high dose or high potency antiplatelets, anticoagulants, stuff like that, and they do fine. Just holding pressure is the key. and that's really the most important part. As far as medication contraindications, I really advise guys not to co-administer these medications with PD5 inhibitors. That is an extremely bad idea. You're attacking the penis now from 5 different mechanisms, right? Or potentially, with all the different potential pathways of smooth muscle relaxation. Really an atrocious idea. Please don't do that, patients. And again, the most important thing I want to emphasize is when you're setting a guy up for his initial visit, check his blood pressure. If he walks in the door and his systolic is too high, his diastolic is too high, you can reschedule for a different day when he's actually taking his blood pressure meds, or sees his PCP and gets on different meds. But if you have to walk into the mystery zone of priapism without knowing that guy's blood pressure is ahead of time, you're really rolling the dice. Then you go to put the monitor on the guy because he's got a priapism, and you start, checking BPs, and you realize his blood pressure is out of control. It's not ideal. You don't have a lot of leeway to push phenylephrine consistently and aggressively. Questions answered. That's all I got.
Alrighty, we had one more question come in, so we have time for one more, it looks like, and this is about lyophilized Trimix being shipped to California. So this is going to be a Lianne question, but to my understanding, we don't ship Trimix that needs to be reconstituted, but perhaps you could speak from a broader perspective why that may be happening to this person that is.
California has a lot of different rules on beyond use dates and testing with the new 797 USP guidelines. So if the pharmacy is not able to do the testing, which we have the testing for all of our products, there are a few that don't have complete testings that we don't send to California, but it's only because of the testing and the new rules. The lyophilized is that they put the powder in the bottle and then they just ship it so that they say it's not compounded. I'm not sure those rules lyophilized with California, but all of our Trimixes are compounded, ready to go. They don't have to be reconstituted.
Or frozen.
Or frozen. We start them off frozen just to give it a longer BUD, which is 120 days. But once it leaves the pharmacy, it does not have to be. We advise the patient to put it in the refrigerator.
Ketchup.
Perfect. Alrighty. Well, thank you for covering those questions, both of you. We're going to go ahead.
There was one other question, and that somebody had written in it and said, "What is my favorite basketball team?" And I just want to take a moment to congratulate my Seton Hall Pirates, last year's 2 years ago NIT champions. Last year we did terrible, but Seton Hall Pirates, that's my college basketball team. Not really a big NBA fan, but that's my jam. Lianne, what's your favorite basketball team?
I'll go with my high school too then. My college team was Pitt, and they didn't do too good at basketball either. Oh, you know what? I got a favorite one, Kentucky, Morehead State, Kentucky. My son went to school there, played football, and their basketball team was pretty good. So that'd be my favorite.
Sweet.
If you'd like to learn more, we do have a couple of options for you. If you have any follow-up questions or you'd like to learn how to get started writing test doses through the MedMD provider portal, feel free to reach out directly to your account rep. They'll be happy to get you set up. And also, if you're looking for more clinical resources, please check out the For Providers page. Here we have curated expert-written articles covering the best practices for prescribing, patient adherence, treatment protocols, and building a thriving sexual health program. It's a great resource to learn from fellow clinicians and elevate your care.
If you found this video helpful and want to stay in the loop with our growing men's health community, be sure to subscribe to our channel and click the bell to be notified when new content is available. Your support makes it easier for other men like you to find these helpful resources. Thanks again for watching. We hope to see you again.